Hello, Dr. Bisakha, you're there?
Yes, ma'am.
Yeah, you can hear me, no?
Yes, ma'am.
Yeah, so we'll start in some time. No? Let the others also join. No? Yeah.
Yes, ma'am.
You got your slides and all ready, no?
Yes, ma'am.
You want to check your slides?
Yes, ma'am.
I can share it once and check. Yeah. Yeah, MRM meet case presentation, right? Put a slideshow.
Yes, ma'am.
Good morning, madam. You're mute. Please unmute.
Yeah.
Yeah, hello, madam. How are you?
Yeah, I'm fine. How are you?
I'm good. Yes, Visakha, your slides are showing. Put the next slide. Just change it once. Yeah, that's fine. You can close it now for now. Yeah. That's fine. Yeah. Okay, madam. I'll get back in some time.
Yeah. I will also.
Yeah. See you. Yeah.
Hi.
Hello. Yeah. So I think Dr. Shubda, Dr. Gayatri are there. Dr. Gayatri.
Good morning, ma'am. I'm there.
Yeah. Hi. Good morning. Yeah. And Visakha, you're there. Hi. Yeah. Great. So I think in another 2 minutes, we will start with our case. Visakha, you're ready, no? Visakha?
Yes, ma'am.
You're ready, no? Yeah.
Yes, ma'am.
So, madam, we'll start because all the faculty are there. The students are, many of them already there. Yeah,
So since it is at 11, I think let us wait for everybody to join.
Okay, 2 minutes. Yeah.
2 minutes are there.
Yeah. Okay.
Good morning.
Good morning.
Good morning, ma'am. Good morning,
Yeah.
Shubha. Good morning.
Good morning.
Sir is already logged in. Yeah. Good morning, sir.
Yes. I'm here. Right.
Okay, so you will join in with the case presentation also?
Case presentation, I will be there. I'll be listening.
Great.
So, if I have to contribute anything, I will contribute.
Yes, please, sir. Yes. Yeah. Yeah. So Dr. Shubda will start. It's 11, I think. Huh? Yeah, you're muted. Yeah. Okay, so good morning, everyone.
Yeah.
Welcome to the April MRA Student-Teacher Interface session. Today, we have a case presentation. The student is Dr. Visakha Jain from PD Hinduja Hospital. Esteemed faculty today are two senior rheumatologists from Mumbai, Dr. Lata Bichle Madam, Dr. Shubda Kalke, and our own Dr. Gayatri Ekbote from Pune. I welcome all of you for the PG clinic. This will be followed by a guest lecture by our IRA President, Dr. B.G. Dharmanan. So welcome you all again. Dr. Visakha, you can start, just try to share your screen and you can start. And over to you, Madam Dr. Shubda and Dr. Gayatri.
Yeah, thank you, Kavita.
I think on behalf of everyone, we welcome Vishaka and other students who are attending the clinic today. I think Vishaka can introduce to herself as to from where she has done her MBBS or MD and how many months of her rheumatology training at Hinduja. Over to Vishaka now.
Good morning, ma'am.
Vishaka, just before we start, I just want to tell you that this is just like a bedside clinic. So don't be under any pressure. This is education, all of us. So just don't worry, be fearless and present, okay?
Yes, ma'am. Thank
Not
you.
some question answer exam.
Different faces.
Yeah.
Good morning. I'm Dr. Vishakha Swain. I have done my MBBS from GMC Nagpur and my MD from Ram Manohar Lohia Hospital in Delhi. And I joined Hinduja Hospital as a DRNB student in December. So I've completed almost 4 months of my training here now.
Yeah, good. You go ahead.
Sure. Okay. So presenting a case today of a 29-year-old male from Ghatkopar, is a clerk by occupation. presented to the OPD with chief complaints of low back pain involving the buttocks since 1 year and pain and swelling in small and large joints since 6 months. The patient has been symptomatic since 1 year. He was well 1 year back when he started complaining of episodic low back pain involving the buttocks, alternating sites lasting 10 to 15 days during each episode. The pain intensity was more in the morning and it was associated with early morning stiffness of more than 1 hour. It was non-radiating, associated with awakening in second half of sleep, relieved with activity and worsened with rest, and had a good response to NSAIDs. He also complained of pain and swelling of left wrist and both his knees since 6 months, and it was associated with early morning stiffness of more than 30 minutes. This was followed by pain and swelling in the second and third PIP of left hand and second PIP of right hand in an additive manner. Pain was more in the morning, associated with stiffness lasting for 30 minutes to 1 hour, and it was relieved with NSAIDs. The patient used to take etoricoxib 60 mg 3 to 4 times a week, and he used to get 70% relief with it. Presently, he finds it difficult to get out of the bed in the morning. He can open a doorknob, can take bath with some difficulty, can dress and undress himself. He has back stiffness with prolonged standing, and pain in both knees increases after a period of inactivity. Negative history. There is no history of any other peripheral joint involvement, no history of painful swelling of entire finger or toe, no history of heel or sole pain, no history of rib or chest pain, no history of redness of eyes, photophobia, eye ache or blurring of vision, no history of fever prior to onset of the symptoms, no history of burning micturition or genital ulcers or oral ulcers, no history of pain in abdomen, blood in stools or loose stools, no personal history or family history of psoriasis, no history of weight loss, no history of promiscuity, and no history of tuberculosis. Personal history. Sleep is disturbed due to pain. Appetite is normal. Bladder and bowel is normal. There is no history of any addictions. The patient is vegetarian by diet and he does not exercise. Past history, there are no comorbidities. Family history, no history of any inflammatory back pain or psoriasis in the family. No history of arthritis in the family. Treatment history. The patient has history of taking tablet etoricoxib 60 mg 2 to 3 times a week since 1 year. Patient had consulted a physician 6 months ago and he was advised painkiller for a month and he has been taking it intermittently. Summary. A 29-year-old male, symptomatic since 1 year with inflammatory back pain, with asymmetrical large and small inflammatory polyarthritis, without enthesitis, without any root joint involvement or other extra-articular manifestations. Most likely a case of spondyloarthropathy with axial and peripheral involvement.
Gayatri, you talked about it started with the buttock pain. So what is your thinking with the buttock pain? What diagnosis would you be thinking?
This seems like an inflammatory pain, ma'am, because...
So inflammatory pain you are saying because of the stiffness, right? More than one.
Yes, ma'am.
The buttock pain.
So
what other, when you say buttock pain, area you are thinking is causing the pain, and what are the causes of buttock pain you know?
You mentioned the word like alternating buttock pain while walking. What it points to?
It can be because of any infection like septic.
Which area are you thinking first?
Sacroiliac joint.
Yeah.
Okay. Yeah. Anything else can cause buttock pain?
You think of the muscles around the buttock and the structures around it so that you will get the answer to the question.
Bursitis can be there. Any
Which
muscle
bursitis?
spasm.
Which bursa is there in that area?
Ischiotuberous, ischial bursa.
Okay. Which are the muscles that cover? What else?
It can
Are
be
you
a
thinking of any nerve root? Can you think of a nerve root there, or you don't want to think?
Yes, ma'am. Sciatic nerve involvement can be there. Sciatica can be there. Compression.
Name the root value of sciatic nerve. Name the root value.
Ma'am, L5, L2 to S1, sciatic nerve.
What it is called? What that bunch is called?
Lumbosacral plexus.
Right, lumbosacral plexus, right? If you suppose you want to rule out this pain of a neurological disease versus a joint pain, and I ask you to do one examination there, which examination you will carry out to confirm nerve versus a joint?
Straight leg raising test, ma'am.
Okay, any other specific thing that will supplies the buttock area? You know the reflexes, superficial and deep reflexes that we elicit in patients usually with the cord.
Yes, ma'am.
So what will be that reflex you will look into?
Ma'am, anal reflex can differentiate.
Anal reflex. Can you get some symptoms of anal incontinence or some spasm there from history? So it is not connected in this case.
Yes, ma'am. We can ask for incontinence.
One is incontinence. Second is upper motor, we ask for the hesitancy. Okay, that's besides the point. You said that the patient has got nocturnal pain. Any other nocturnal characteristic of pain in a patient whom you are suspecting sacroiliitis or axial spondyloarthropathy?
Yes, ma'am.
Which particular movement is painful in the night and the patient's sleep is disturbed?
Ma'am, the patient complains that cannot turn on the bed or has increased pain when he's tossing and turning on the bed. Yeah,
so that should be one. You are not mentioned in the history. So always keep that point in the history.
Yes,
do we know any specificity or sensitivity of these symptoms that we ask in the history to a patient suspected to have actual SPA? Which questions we ask to the patient? You are included most of them, but you are remaining. You can just narrate. One is pain. Second?
Pain and early morning stiffness.
Right. Third?
Nocturnal awakening.
Pain. Fourth?
Getting better with activity and increasing with inactivity.
Inactivity. Fifth, while turning in the bed. And whether you are able to bend in the morning forward to pick up the objects.
Yes, ma'am.
So because all these things will take you near to the diagnosis of spondyloarthropathy. Right?
Yes, can buttock pain be caused by the hip?
Yes.
Or hip pain comes somewhere else?
Usually in the groin area, ma'am, anteriorly.
Correct. Very good. And so sacroiliac, when you say sacroiliac joint, there are a lot of structures around sacroiliac joint like sacroiliac ligaments, gluteal muscles. Bursitis, you are absolutely right. But, the commonest bursitis is trochanteric bursitis, where the pain is felt in the lateral area. My idea was to differentiate the anatomical area of pain and your diagnosis. Saying inflammatory back pain. Inflammatory back pain is very clear and all of us see day in and day out. So when somebody says buttock pain, these are the things which run through your mind. You mentioned infection. So how you think, why you think there was no infection in this patient?
Ma'am, it is bilateral and there is no fever, no constitutional symptoms as such, and it is a very long history. So definitely not an acute infection, but even for it to be chronic, it is bilateral. So infection seems to be a bit less likely. And it is relieved with anti-inflammatory drugs.
Right. Good, good.
Vishaka, I have one more question for you. How could you tell on history that patient does not have enthesitis? Because as ma'am pointed out, inflammatory back pain, as they said, they told you very clearly that there are many muscles around it. And SI joint pain is usually, predominantly SI joint pain is because of enthesitis of the muscles around it, okay? And second thing is, you can say that there is no dactylitis on history, but you already have mentioned that patient has been taking NSAIDs on and off. Okay, so we really cannot rule out enthesitis or even dactylitis for that matter on just history. Okay, you need to examine the patient for that.
Yes.
And what will the enthesitis patient tell you?
Yeah.
That's a very important point Gayatri mentioned. You said there is no history of enthesitis. So what did you ask for history of enthesitis?
Basically heel pain and rib pain mostly, to rule out any tendo Achilles enthesitis or costovertebral involvement.
Can knee pain cause enthesitis?
Yes, ma'am. Patella and tibial tuberosity pain might be there. There might be post-inflammatory pigmentation because of enthesitis as well.
Correct. So when you say no history of enthesitis, when patient has pain and stiffness and swelling, sometimes they may not be able to give you the enthesitis history. As Gayatri mentioned, you pick it up on examination. So
yes,
enthesitis is not that easy.
Yes, ma'am.
Okay.
You mentioned some wrist pain also, no, in this patient?
Yes, ma'am.
So what could be the cause of that wrist pain, and how frequently wrist is involved in patient with hang spot?
There can be asymmetric oligoarthritis and spondyloarthropathy, and it may be involved. So almost 30% of cases in spondyloarthritis can have peripheral arthritis as well.
Right. Is it the upper extremity or the lower extremity, large or the small joints are involved in spondyloarthropathy?
Ma'am, usually lower limb and large joints are more commonly involved, like knees and ankle. But upper limb joints may also be involved.
Is it always symmetrical, asymmetrical?
It's usually asymmetrical, ma'am, but it can be symmetrical.
So the learning point is, it is always large joint, asymmetrical in the lower limbs, and upper limbs can be also involved. If suppose this patient, suppose you get history of psoriasis in the family, which particular joint will examine in the upper limb?
Distal interphalangeal joint.
Which particular fingers? The lateral ones or the medial one?
I'm not sure.
You're not, but usually it is the second and the third, because they are the ones which are actually, and the lateral two fingers on their side, they have got a function of a grip, right?
Yes.
Your history was okay, but I felt that you are not asked any positive or leading questions pertaining to the eye in this particular patient. Which questions you would have asked to the patient?
Redness of the eyes and photophobia, pain in the eyes.
Anything else? Which is the first symptom that usually comes and goes, and patient was on NSAIDs as well? Name the structures in the eye so that you get the answers. Name the structures in the anterior chamber so that you get the answers to my question.
Iris, the lens. And
what did you say?
Iris, lens, cornea.
No, anterior chamber. Start with conjunctiva, no?
Yes, ma'am. Conjunctiva, sclera.
Sclera, then cornea, then iris.
Then iris.
Then retina and blood vessel nerve. Okay, so which symptoms are common in these patients?
Usually redness, uveitis can be there.
Which one is common, anterior or the posterior uveitis is common?
Anterior uveitis and ankylosing spondylitis and enteropathic associated arthropathy, and posterior in psoriatic arthritis and reactive arthritis.
What are the various components of anterior uveitis so that you will not forget?
Usually there is alternating sudden onset redness in the eyes with pain and blurring of vision. Usually it's alternating, both the eyes will be involved, but at one time, one eye is usually involved.
Yeah, you are correct. This history, you have to always ask this history of anterior uveitis in all patients with angstpon, irrespective of a male or a female patient, because they will forget to inform you. But then you know that this patient has first manifestation anterior uveitis, and now he's coming to you after a visit for orthopedic to you with full-fledged symptoms of axial spondyloarthropathy. Right, good. So what is your conventional diagnosis from the history? Or Shuddha, you want to ask? Gayatri, you want to ask some questions?
The patient had never seen any rheumatologist, no? Vishakha?
No, ma'am.
Okay.
No, ma'am, not a rheumatologist.
And nobody advised him to do exercises?
Yeah.
Ma'am, the physician had advised him, but he didn't follow that.
Just to ask you, Vishakha, you think that the dose of etarocoxib was adequate, or you would like to add something, or you would like to say a few lines on the painkillers as a whole in patients with angst?
Yes, ma'am. Ma'am, it was inadequate, definitely. At least we should give it for around 4 weeks continuously, at least 20 days continuously for it to respond, because the edema persists for a long time.
Right.
So intermittent NSAIDs will not help the patient. It has to be continuous.
Okay. Okay. Which way in the history of this disease, which painkiller was given first, and most of the patients remain on this painkiller for a very long time? You know the NSAIDs used in patients with angst?
Yes, ma'am.
Just name the NSAIDs.
Ma'am, etoricoxib, then diclofenac or Voveron, and ibuprofen.
In the natural history of the disease, if you refer to the textbook, you will read the name of only one NSAID, because these are newer NSAIDs. Indomethacin?
Yeah.
Yes, ma'am.
What is the dose of indomethacin?
25 to 50 mg.
What is the rule of giving NSAIDs in patients with angst? One is give the full dose and give it for a sufficient time. Then, what are the precautions? What are the precautions while giving NSAIDs in patients with angst? Your patient does not have morbidities.
Gastrointestinal, and there might be renal implications. So usually we should give we should give an antacid with it, maybe Pantop, because there can be erosions, NSAID-induced ulcers.
Right. So avoid it in patients with hypertension, ischemic heart disease, and get a history of abdominal pain associated with food ingestion.
Yes,
that will give us the status of gastric or duodenal mucosa for that purpose, right? So this question should be asked to any patient who is on chronic NSAIDs. Okay, go ahead.
General examination, vitals, temperature was 97 degree Fahrenheit, pulse was 72 per minute, blood pressure was 120 by 80, height was 178 centimeters, weight was 80 kg, making his BMI to be 25.2. Skin was normal. Hair, there was no evidence of psoriasis or any dandruff. Nails normal. Oral cavity normal. Eyes no redness. There was no pallor, icterus, clubbing, cyanosis, lymphadenopathy, or pedal edema. Then in musculoskeletal examination, the posture was normal. Gait was abnormal due to pain in the knees.
Can I interrupt you here? What things will observe in the posture?
Look for kyphosis and then
kyphosis where? Kyphosis
thoracic, mostly thoracic kyphosis, ma'am. And
it as dorsal spine. Okay, okay,
yes,
thoracic. Okay, right. Any other thing?
Then loss of lumbar lordosis.
Right.
So what is that gait called? Because in the knees?
Antalgic gait.
Yeah. And you mentioned general examination. So can you tell me what is the importance? You have mentioned skin, psoriasis, nails, hair, psoriasis, eyes, etc. But what is the significance of height and weight? Where will we use it relevant to this patient?
Right.
Why do you take a height and weight? Is it really necessary, or it's just a part of examination?
No, ma'am. in psoriatic arthritis, there might be metabolic syndrome. And also there is importance of weight reduction as well in this condition, as decreasing the weight will put less strain on the spine and the joints as well. So
okay, so one is weight gain, weight loss.
Yes, ma'am.
Means what if the weight is more and what if the weight is less?
Ma'am, more, if it is
more,
more
you said,
than yes,
metabolic syndrome and all that.
Yes, ma'am.
Less?
And if there is a history of weight loss, then that implicates a active disease.
Okay, what else is the importance of weight in every patient? Why do you take weight?
So when we take a weight, is it the weight of the bone? Is it the weight of the muscle? It is everything of weight, muscle, bone, weight plus the fat and abdominal fat. What would you prefer?
Lean.
You want patient to be lean.
No.
No, it's all right.
The lean mass, basically.
Okay. Other thing, if suppose the body mass is index and you want to give an advice to the patient, what is your rationale behind this, taking weight and advising the patient to reduce the weight?
Yes.
Are the fat cells involved in inflammation? That's what I think Shuddha wants to ask you.
Yes, ma'am.
So just tell us on that. What is a fat cell called?
Adipocyte.
And what are the cytokines? What are the medicine? Why we ask the patient to reduce the weight? Does the fat increase fat mass adds to the degree of inflammation?
Yes, ma'am. TNF alpha may be raised in these patients.
No, you're not getting, okay. You can read on that, right? Because we always ask the patient to reduce weight because each fat cell has got receptors which will add to the inflammation.
And what is the importance of height, Gayatri, Vishakha? Why do you need height?
Yes. Vishakha madam is basically asking you whenever you take serial measurement, okay, on follow-up, you do BASMI, right?
Yes, ma'am.
Yeah, so why ma'am is asking you importance of height? If it gets reduced in the next follow-up, what do you think?
There might be stooping or kyphosis. Because
so one thing is to monitor. Both height and weight are important to monitor the patient, right? Whether they are gaining weight on your medication, losing weight on your medication. If you have advised them a diet, are they following it? Are they losing weight in that? Height-weight ratio is important for you to decide whether they are overweight or not. Weight you may be using to calculate the dose of the medication.
Yes, ma'am.
That is why you need, they look like very simple things, but they are important. We take it routinely and we don't think beyond that. But everything you do has a reason and a meaning. We are not doing it for the sake of it. Why would you take pulse in ankylosing? Is it really important?
Ma'am, there might be some complications or extra-articular manifestations like AR, aortic root dilatation.
Okay.
So it is important for that also.
What else? Why do you BP?
Yes, so this patient gets a pulse rate of, you measure it was 70 and after says 2 or 3 years it comes to the pulse rate of 40.
There are conduction abnormalities.
Yeah, conduction.
Yes.
So it indicates the active disease and its extra-articular complication. I think on posture, you must say that most of the inflammatory diseases have osteoporosis as an accompaniment.
Yes.
So the patient's bone strength will be lost and we have to take into consideration inflammation-related osteoporosis and treat it simultaneously, right?
Yes.
Okay.
Why do you want to take BP? He's a young fellow. Do you really need BP?
You have mentioned in the history, personal history or some history you have mentioned.
Any other students can also answer.
Yeah, it's not, we are not bombarding only on Vishakha.
Yeah. Dr. Akanksha and Dr. Aditi or Pooja.
I think, ma'am, we should only start asking them.
Yeah.
Actually. So let's give Vishakha a little break. Let anybody else answer.
They'll hate me for this now. We can check whether they are awake.
No. I like you for this because we are just bombarding one person who has to present.
Yeah. So let's see who's the Akanksha.
So basically, Akanksha, anything you want to add?
Yes, bolo chalo.
Good morning, everyone. Ma'am, the importance of blood pressure in this case, I think, is to rule out like extra-articular manifestations like AR would produce a higher pulse rate and would be
pressure.
How many cases of AR have you seen in your career so far?
Ma'am, in AS, one was suspected but did not turn out to be AR.
Correct. So I respect your answer. It is correct, but it is not the commonest thing. What is the commonest thing why you want to take blood pressure in such patients?
Patient is on NSAIDs. So NSAIDs can lead to glomerulonephritis in some cases if it's abused because they're on long-term NSAIDs. So it's
on top of that, you are giving etoricoxib to the patient, which you may continue long-term. So if the blood pressure is rising in psoriatic patients, if you are giving cyclosporin to these patients, you need to monitor the blood pressure for all these things.
Yes.
So Aditi, you said about glomerulonephritis, right? Just don't say it. I mean, it's not just always glomerulonephritis. That could be one of the last stages. There is just heightened RAS. TIN or heightened RAS. Okay, so there are multiple causes of hypertension due to NSAIDs. Okay.
Suppose this patient had something like a Reiter syndrome. Was auscultation of aortic area important in this case, or will you auscultate it there?
Yes,
anyone can answer.
So Deepti,
yes,
could you answer? Deepti, can you answer this question? Why ma'am is asking about Reiters and auscultation in aortic area? Which disease will you think about? Deepti, are you there?
How Reiters differs from established AS?
Ma'am, in Reiters, usually there is asymmetrical sacroiliitis. While in ankylosing spondylitis, there is symmetrical bilateral asymmetrical sacroiliitis.
Which patient looks sick? Which patient looks sick?
Reiters. Then there can be other manifestations like skin manifestations in Reiters, Cercin balanitis and keratoderma blennorrhagica, involvement of the nails.
Right.
Okay, now you mentioned the general examination, no pallor, icterus, clubbing, cyanosis, etc. Tell me how it is significant, pertinent to this case. Suppose you found pallor, then what would you think of?
Pallor can be because of inflammation as such due to any...
So pallor means anemia. So anemia, yes, one inflammation. What else?
Then IBD, if there is IBD and there is perrectal bleeding, that can also lead to pallor or anemia. Okay. Then
which IBD? Would you like to specify?
Ma'am, usually Crohn's is more commonly associated than ulcerative colitis, but both can be a part of spondyloarthropathy.
In a patient with ulcerative...
sorry, madam.
No, it's all. In a patient
this patient is...
you go ahead.
This patient is on etoricoxib, but other NSAIDs also can cause blood loss.
Yes, ma'am.
It will be important to note that some people, because of inflammation, also are not eating well. So they may have iron deficiency, anemia also. So all this this is the inference. If you see anemia, this is what you want to look at.
Yes, ma'am.
A significance of icterus.
Icterus in patients with expand. She wants to know.
Many drug toxicity for peripheral arthritis.
Peripheral arthritis, icterus.
Anything you would like to say?
Then
have you heard about PBC and IBD overlap, Vishakha?
Yes, yes, ma'am.
Yeah, so that's what they are asking about, importance of icterus in SPA.
Yes.
Clubbing, when do you get clubbing in SPA?
Ma'am, inflammatory bowel disease can lead to clubbing.
Okay. Right, and even you can have those pseudo hyperparathyroidism cases when you do not have proper SPA, I mean inflammatory, but you might have some sacroiliitis. There are differentials. Okay.
Yes.
Yeah. Right.
Fine, you can go ahead. Just point I want to make here for everyone. We all do general examination and we are used to saying no history of da 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 da, but we don't think in specific case why.
Yeah.
And actually in every case there is a significance of why we are saying it. So we all should actually, when you are saying it, you should think why I am saying it. Okay, that's why, nothing else.
Yes,
because if we say no and you don't get the answer, that means you are not given a thought to the history and interpretation of your findings. So don't allow the examiner to raise the questions. Right? You can go ahead.
Yes. Peripheral joint examination. DIP was normal on inspection, palpation, and movements were normal. PIP, the right index and left index and middle finger swelling was there. There was tenderness and range of, and the movement was painful. Metacarpal squeeze was, there was no pain. Left wrist, there was swelling, tenderness, and movement was painful. Elbow and shoulder normal.
Right.
In lower limb, hips were normal. Right knee swelling was there. It was more than the left knee. It was warm. There was moderate effusion and patellar tap was positive. The movements were painful and restricted. Left knee swelling was present. It was warm. There was mild effusion. The terminal movement was restricted and the range of and the movement was painful. Ankle and PIP, DIP subtalar joints were normal. MTP squeeze, there was no pain. The sternoclavicular and acromioclavicular joint were normal. Enthesial sites were normal.
What is the significance of, suppose you had found sternoclavicular syndrome or sternoclavicular joint swelling? Is there any significance?
Which are the conditions? Which are the conditions where you find sternoclavicular joint being affected?
SAPHO.
SAPHO. That is
what is the full form of SAPHO?
Synovitis, acne, and hyperostosis, osteitis, pustulosis.
Okay. Any other disease that comes with sternoclavicular? He's also he's also a boy of 29 years.
IV drug abuse.
IV drug abuse is important. Even HIV has
HIV.
Even STD related can come like this. Okay.
Yes.
Which particular joint is affected in gonococcal infection as STD?
Usually upper limb joints, ma'am.
Which particular joint in the wrist? Okay. Is TB possible at sternoclavicular joint?
Yes, ma'am.
That is yes. Okay, chalo, go ahead. You said you have looked for the enthesis. Which enthesis sites you have palpated and said that enthesis are normal?
Ma'am, tendo Achilles.
One tendo Achilles,
then the tibial tuberosity,
right.
The superior and inferior borders of the patella,
Okay.
Greater trochanter, and greater trochanter, the greater tuberosity and spinous processes, and the costovertebral joints.
Right. Anything in the foot for which the patient really comes to you?
Plantar fascia.
Because I've forgotten it. Even in history, you're not asked it, right?
Yeah.
So plantar fascia is the commonest presentation, costochondral junction, right?
Yes.
Okay, right. If suppose there is persistent costochondral junction pain in spite of adequate therapy, what does it indicate? Is it a sign to be neglected, a symptom to be neglected? You have to reconsider the therapy.
Yes, ma'am, reconsider the therapy.
But in what form? Is it a sign of active disease?
Yes, ma'am.
What is it?
It could be a sign of active disease.
What do you understand by recalcitrant enthesitis, and which are the common sites? Difficult to treat. Enthesitis, difficult to treat with a lot of morbidity. Is tendo Achilles recalcitrant? Is there a bursa there which needs to be tackled?
Yes,
what about plantar fascia?
Yes, ma'am.
So these are the sites. And suppose these are cured and there is persistent chest pain and patient just can't even breathe because of that, is also a sign of persistent active disease, and we can give even biologicals. I have used in 1 or 2 patients, not on all patients, right? Okay, right. Anyone wants to ask? Shuddha?
No, she can go.
Or Gayatri?
Yes. What is modified Schauber's?
When modified Schauber's, in that we take a point on the dimple of Venus or the posterior superior iliac spine, and we mark a point 10 centimeter above it and 5 centimeter below it. When we ask the patient to bend down with his knees straight, usually, so this distance should actually increase by more than 4 centimeter. That is normal. If it is less than that, then the lumbar flexion is said to be restricted.
Okay. So Shri Lakshmi is there. Last question too. Last question in examination. Shri Lakshmi, are you there?
Yes, ma'am.
Yeah. So what is Schauber's and how it is different from modified Schauber's?
Lakshmi, are you muted?
So
there's some connectivity issue.
Yeah, there is some connectivity.
Maybe somebody else can answer.
Akanksha, you want to answer this
Akanksha
question?
can answer, yeah.
Ma'am, in Schauber's, we, I think, don't take the 5 centimeters below part. We only take the 10 centimeter part and check whether it on forward bending it is increasing by 4 or 5 centimeters or not. But now, most commonly, ma'am, we like to use modified Schauber's, in which the 5 centimeter part is also measured.
Okay. Right. Can we go ahead, ma'am?
Yeah. Please go.
Yeah.
Fine examination. On inspection, there was no obvious deformity. The overlying skin was normal. Measurements: wall to tragus distance was 6 centimeter. Wall to occiput was 0 centimeter. Modified Schauber's test, 3 centimeter change was there. Chest expansion was 4 centimeter change. Finger to floor distance was 40 centimeter. Lateral flexion 9 centimeter. And the intermalleolar distance was 104 centimeter. Palpation: there was no tenderness over the spinous processes. There was no paraspinal spasm. In the movements, the cervical spine and thoracic spine movements were normal. Lumbar spine flexion, extension, and lateral flexion were restricted. And sacroiliac joint examination: Faber's test, the sacroiliac stress test was positive on the right side, and the straight leg raising test was negative.
How do you measure thoracic flexion extension?
Actually, it is done in the same way. We do shoulders, and for thoracic involvement, usually there is 3 to 4 centimeter change we see over the thoracic spine.
How? Shoulders is done only in lumbar. The reason I mentioned is there is no specific test, and thoracic spine is difficult. See, cervical and lumbar spine are mobile, so they are easy to examine. We know that there is a thoracic restriction, but we hardly measure the restriction or rotation in the thoracic spine.
Yes.
And what is the score which you mentioned on the left side? Is it called some score?
Yes, BASMI.
Okay. And do you calculate it every time?
No, ma'am. No, not every time.
No, why not?
Yes, ma'am, we do.
How often do you calculate?
Ma'am, it should be calculated in every follow-up to look at the progression of the disease.
What does it indicate? Does it indicate activity of the disease or chronicity of restriction? Just indicates chronicity.
Indicates the chronicity mostly.
Only?
No, if there is a significant change from the last time, it means that the disease may have been active and it has caused some damage now.
So basically, if there is a change, you only notice the change. You don't know whether it is active. You cannot be 100% sure whether it is activity or chronicity. And if it is a chronic restriction, then in fact, the progression can be difficult to assess despite active disease. So what do you want to do for any other thing you do for active disease? Any other score you do?
We can do BASDAI or ASDAS.
Do you know what they are?
Yes, ma'am. BASDAI, we have basically 6 questions, which like we ask, we check the last 7 days of the patient, how much fatigue or tiredness the patient has had, and the discomfort that the back pain or hip pain or the buttock pain or the neck pain has been causing the patient, or the discomfort that the peripheral joint pains have been causing the patient, and the discomfort that the tender points on the joints have been causing, and discomfort while waking up, and the duration of the early morning stiffness. So basically, we take the average of the last 2 questions and we add it to the first 4 questions and divide the entire thing by 5. And that is how we measure the BASDAI. So a BASDAI more than equal to 4 indicates disease, active disease, basically.
Sure. Yeah. Okay. You can go ahead. The only point I wanted to make is that's why you use the other score so that ESR and CRP will help you.
Yes, ma'am.
That is not there in BASDAI, but yeah, you can because we'll have to wind up soon.
Yes. Other systems were normal.
Okay.
Diagnosis: spondyloarthritis with axial involvement with bilateral sacroiliitis with asymmetrical large and small joint polyarticular inflammatory peripheral arthritis without enthesitis, dactylitis, uveitis, and root joint involvement without extraarticular features or any complications.
So how do you want to treat this patient?
For
what investigations you will do? Sorry.
We'll do CBC, the inflammatory markers, ESR and CRP, and liver function tests, and creatinine of the patient.
Why liver function test and creatinine?
Because the patient has peripheral arthritis, we may have to use sulfaparidine and methotrexate. So for that, we'll have to be sure that the LFTs are normal. And
even for NSAIDs, you need to be sure about LFT and creatinine, right?
Yes, ma'am.
Yeah.
Yeah. Okay.
Then I would like to do X-ray of the sacroiliac joints and the X-ray of the lumbosacral spine as well.
X-ray is normal then?
If the X-ray is normal and the disease is active, we can go ahead with a MRI of the sacroiliac joints with a stir sequence and the LS spine as well.
Patient is not affording.
Then in that case, ma'am, we can treat the patient clinically.
Good. Yeah. MRI we do commonly, very often nowadays, but it is not mandatory. Okay.
Will you advise a bone scan?
Your diagnosis, you don't need.
Can you advise bone scan in this patient?
We can advise a bone scan.
Because during examination, it didn't get enthesitis. You got only arthritis, and I think you talked of right sacroiliitis, and I think left was normal, though he had alternating back pain.
Yes, ma'am.
So we have to, why do we do all these investigations actually?
To confirm the diagnosis.
One is to confirm the diagnosis. Second?
We may not get everything clinically, which might show up in the...
Third thing, it's a quantum of disease that will be helpful to you, because lumbar spine is not symptomatic, but on an MRI, you'll be able to pick up some lesions even in the lumbar spine as well, right?
Yes, ma'am.
You might will be even able to pick up enthesitis as well. So it is a load of inflammation and stage of inflammation. Can you narrate the stages of inflammation in patients with angstcon, with a disease of 2 years duration in this case, so that you can plan the therapies? Tell us the stages of inflammation on MRI.
There will be bone marrow edema.
Right. Second, at the edges of the vertebrae.
And erosions. Erosion
means the disease is established. Before that, they call some nodes, some more. What is that?
Shiny corners.
Shiny corners. On MRI, how do they look? What is the name for it?
Ma'am, Romanus lesion.
Okay. Any other thing? Why there is always a miss for osteomalacia? How does it mimic osteomalacia vertebrae at some sites? Or these patients are vitamin D deficient and it adds to it. What does it mean?
Because of the inflammation, there is osteoporosis as well in ankylosing spondylitis.
Okay.
And there is, when the spine becomes rigid, there is such mechanical stress on it, because of which again further osteoporosis occurs after the ankylosis.
Okay. So suppose you had some edema in the vertebra. What is a pre-runner of which particular process pathologically later? It is a predecessor, and we don't happen it to go further.
Syndesmophytes.
Yeah.
Syndesmocyte formation.
You prefer a patient with syndesmophytes, or you don't want syndesmophytes on your patients?
No, ma'am, we don't want.
So this is the way we plan our investigations, to give the best treatment opportunities to the patient, so that patient doesn't develop a permanent anatomical damage with the formation of desmophyte. That is the principle of treatment in angstcon.
Yes, ma'am.
What do you understand by non-radiological SPA?
Non-radiological SPA is basically in which we do not find any changes in the X-ray, but we might get the changes in the MRI.
That means we are looking for the treatment opportunities or video of treatment.
Yes, ma'am.
So this word is very important, from institution of therapy at proper time and proper dosage and proper choice of a anticytokine as well.
Yes, ma'am.
Okay. You can read further on this.
How do you want to treat this patient, Vishakha?
Ma'am, I would like to start with a proper NSAID therapy. I would like to give the patient continuous NSAIDs for at least a month at the maximum dosage. And then I would like to reevaluate him to see whether he has done well with this therapy.
Suppose patient has been on Voveran earlier, his SGPT is 100, then what will you do?
Is there any hierarchy of NSAIDs?
Yes, ma'am.
This is in the clinic, no? You must be seeing patients abnormal SGPT. What do you do normally?
Usually.
Anybody, Akanksha, do you want to answer? It's not bombarding at Vishakha only.
Ma'am, COX-2 inhibitors instead of non-selective.
Okay. And suppose the creatinine is high?
If the creatinine is high, no NSAIDs are safer.
So what will you give?
What will happen to abnormal liver functions on stopping the NSAIDs? You can buy some time, no? Or no?
You can give Ultracet or other medication, no? For the time. Yes, but still there are some options if the creatinine is on the higher side, right?
I think we'll have to wind up because...
Okay, fine. So how do you want, last question, how do you want to treat this patient further? Apart from NSAIDs, beyond NSAIDs.
Ma'am, patient education is important, making him understand that this is a chronic disease and medication is a major part, but also that the physiotherapy and exercises will have a good effect on the course of the disease. And for the peripheral arthritis, we can use drugs like SARS and methotrexate as well.
Okay. Good. And what else? Anything about the diet in ankylosing?
No specific diet as such, but weight loss would help the patient.
Low carb diet is suggested in ankylosing. That is supposed to help the inflammation and that will help reduce weight also.
Okay. Vishakha, I have one question. You may not answer now, but you can read about it. So will you still do HLA-B27 in this patient?
Right.
It's...
you can read Aram say.
Yes,
okay, so it's a controversial thing. I mean, it's up to you, but will you do, if patient is affording, we probably will do. Yeah, and if why would we do? And if not, why would you not do? Okay.
Yeah, so that's a very good question, Gayatri. Yeah.
Thank you. So just think about these possibilities because you might practice in government setup letter or you might practice in corporate setup letter. So you have to think about these possibilities also. Okay.
Yes.
Thank you, Vishakha. It was a very good case presentation.
Yeah, Vishakha, you have done very well. Don't worry about your probing question. That is just to help you to ultimately
think on the spot and answer.
Yeah.
You have to read simultaneously as you see patients with NSAID-induced problem or a choice of a drug. Why do you use that drug, right? The question like HLA-B27. I think you were very good in your history interpretation and even in physical examination. You have to find at least 2 hours from your day-to-day schedule to read and go back and read and draw your own notes.
Yes.
Right? Suppose this, because you have totally forgotten the history of anterior uveitis, right? Because this is a disease of the predominantly of the female. Read also ankylosing spondylitis in female patients, the clinical course, whether they are similar or that is similar.
Yes, ma'am.
Okay.
Thank you, Bichle Madam. Thank you, Dr. Shubhta. Thank you, Dr. Gayatri. Thank you, all the students. Dr. Tharmanan sir, would you like to just give a few words about feedback of the session before we start your talk?
Yes. Thank you, Kavita, for the invitation. I thoroughly enjoyed the discussion and the quality of presenter was very good. And of course, I have a first-hand experience of listening to the teaching abilities of Lata Madam and all the other faculty who are there today. And I thoroughly enjoyed it. Thank you. Thank you for asking me to be here today.
Thank you again, teachers and students, for being there. So we now go over to the second part of the, Vishaka, you can stop sharing your screen. And sir, you can start sharing, so on behalf of MRA and all the faculty and students today, I welcome our esteemed guest speaker today, Dr. B.G. Dharmanan. As you all know, he is a senior and renowned consultant rheumatologist at Manipal Hospital, Bangalore. And he's been the past secretary, past vice president of IRA, past president of Karnataka chapter of IRA. And at present, he's our well-known president of the Indian Rheumatology Association. His talk today will be on the topic of fibromyalgia. Is the pain real or imaginary? Welcome you, sir, and looking forward to your talk.
Thank you, Dr. Kavita, for the invitation.
So just 1 minute. Yes. Dharmanand, I just wanted to say a thank you from all of us also. I mean, for agreeing to speak to our students and taking out time from your schedule. So thank you so much for that. Yeah.
My pleasure. Thank you, Rohini. So today I shall have a brief discussion about fibromyalgia. This has been a difficult topic. And I hope some of you can recognize the photographs in this page. To our right is the famous Florence Nightingale. She was, from her description, it looked like she might have suffered from fibromyalgia. The other painting is a self-portrait of Frida Kahlo. She's a very well-known Portuguese, Argentinian painter. And all her self-paintings showed that how much pain she was suffering from. So fibromyalgia has been an elephant in the room. So we use this terminology to explain a very big issue, which everyone is aware of, but which is being ignored because everybody finds the discussion about it uncomfortable. And patients, they have tried to tell their doctors many times, and many times they don't get a good response, or they get referred to psychiatry. And as doctors, we rheumatologists, we are not trained in dealing with these kind of patients. So we are also uncomfortable. So we tend to bury these symptoms and this illness in the carpet and move on with what we know and what we are good at. So it is common. So 3, 4, 5% of the population, depending upon the studies, it's a prevalence of fibromyalgia in the community. But if you look at any rheumatology department's registers, so we find it very rarely. And when we were doing DM, there was no computer. So we used to every day after the OPD, we used to write down the diagnosis in a ledger. And it was maintained since 1974 or 75 by my professor, A.N. Chandrasekharan. And a quick look at the records, we can't find any suggestion of fibromyalgia, and occasional one patient in maybe once a year or twice a year would carry a diagnosis of psychogenic rheumatism. So most of the patients were probably not recognized during that time. And even one of my examiner, when we were discussing, when I was a student, I asked, sir, we are seeing a lot of fibromyalgia. The reply from him was, I have not seen any. So that was a situation in 1997, 1994, 95. And we have come a long way. We are able to recognize, many of us are able to recognize this illness, though we find it, we are at a loss in managing these patients. Why? Because our training is predominantly immunology, and we are trained to be autoimmunologists. And even our degree now reflects it. We are rheumatologist and clinical immunologist. We base most of the diagnosis based on our history and labs. The physical examination, unfortunately, is probably becoming a dying art. sorry to say that, I think this is not been stressed in the training programs of late. And we also listen to what we want to listen, and sometimes conveniently not listen to something which has been told by the patient, or we are not sensitive to non-verbal cues given by the patients. And we also see what we know. It's a famous adage, I see only what mind knows. And I also, in a busy practice, we don't have time to listen to a long story, which is typical of a fibromyalgia patient. So I'm sure many fibromyalgia hides under many names. It could be seronegative RA, seronegative inflammatory arthritis, non-specific arthritis, or undifferentiated connective tissue disease if ANA comes positive. So this is where we are in our current training. It's a difficult problem, both for patients and the doctors, because there is no test and diagnosis is made clinically. And making a diagnosis is one thing. And the bigger challenge is to manage the patient and even convincing the patient that they have a disease like this, because patients are convinced that they have something very serious or much more recognizable like rheumatoid, lupus, etc. So fibromyalgia to a certain extent exposes our inadequacy as a clinician, thus humbles us. So we sometimes it's a buster to prevent us from getting egoistic and no, I know everything kind of attitude, because we feel sometimes helpless in treating these patients adequately. Is it common? Definitely yes. And some of our studies showed a lot of patients who have soft tissue rheumatism. Many of the soft tissue rheumatism could have fibromyalgia component. 20% of the rheumatology clinic in most of the surveys revealed fibromyalgia. And 30% of the GP patients see patients with musculoskeletal pain of uncertain significance. Many of them have fibromyalgia spectrum disease. They also hide in very many clinics as non-cardiac chest pain, vulvovaginal pain in gynecology, or non-specific IBS with gastroenterologist, and chronic tension headache in neurology clinics, etc. So who is a typical patient? Predominantly young women, but men are not totally spared. Widespread aches and pains. So when patient has pain everywhere and associated with fatigue, sleeping difficulties, chronic tension headache or migraine, irritable bowel syndrome, irritable bladder, and sensitive to everything. If the patient gives you a history that I've tried this, I tried that, I don't tolerate this, I don't tolerate even crocin, I don't tolerate allopathy, I don't tolerate so many things, then probably it's something called they're hypersensitive to everything. And they show affective symptoms. And many of these people might have an adverse childhood experience. We need to explore it. So in other words, too many symptoms suspect fibromyalgia. Too many autoantibodies is lupus. Too many symptoms is fibromyalgia. So it is a short name for a long list of symptoms. In a clinic, most of the patients are convinced that they have a swelling. They might show you their hands and say that there is a swelling. And as a clinicians, we may not be able to elicit that swelling easily. So it's a subjective swelling than objective. This is very typical of fibromyalgia. It is more like virtual reality for the patients. The patients do feel the swelling. It is not, they're not faking it. They're not acting. So they feel the feeling. If you have ever had a dental treatment, if the dentist gives you lignocaine into one of these dental region, you feel numb on the entire face and you feel that the face is swollen, but you look at the mirror, face looks normal. So that is kind of swelling it is. And if the patient showed distress during physical examination, and when you are palpating the, like for tender points, if they feel very winds, they show distress, it is very likely to be fibromyalgia. And they seem to enjoy the pressure of palpation. If you are looking at the trapezius and examining, they say, itni maza hai. When they feel enjoy it, probably it is not fibromyalgia. It is something else. It's achy muscles, but not fibromyalgia. And they might complain that they had pain during blood pressure checking. And that is also an important clue for you to suspect fibromyalgia in the clinic. And they will have pain in the joints, but they also have pain away from the joint. This is where we have to look at these joints. We should include evaluation for fibromyalgia-ness in every patient with rheumatic disease, because they can coexist significantly with rheumatic diseases and affect the prognosis, affect the treatment choices, etc. And we have multiple criteria, which I will not run through. You are all familiar with these criteria. And you don't need always criteria to make a diagnosis, but criteria do help in helping us to pin down the diagnosis. So, ladies and gentlemen, if you have a patient presenting to you in the clinic with widespread aches and pains, in other words, pain all over, we generally think of 4 or 5 groups of diseases. Is it a systemic inflammatory rheumatic syndrome? And very early connective tissue disease, very early rheumatoid arthritis can have widespread aches and pains. They may not show the distress, but in no time, in months, they evolve into a rheumatic disease. So when we see them in a very early pre-clinical autoimmunity phase, sometimes it can be difficult to differentiate it from fibromyalgia, but time always will tell. If somebody comes to you with pain of 10 years duration, it is not a pre-clinical autoimmunity. It is fibromyalgia or some other disease. And another question is, does it represent rheumatic symptoms or musculoskeletal symptoms of an endocrinopathy? Is it drug-related? Keep this in the differential diagnosis. Keep drugs in the DD for all your clinical illness. If somebody comes to you with hair loss, look at the drugs. If somebody comes to you with leg swelling, look at the drugs. It could be a cardiac drug, it could be hypertensive drug. There are lots and lots of new drugs have come in the other fields, which we may not be familiar at all because it was not there when we were training. My youngsters may know a little bit. I have no clues about what are the side effects of newer anti-diabetics. So I have to go back and see. And the fourth basket is it fibromyalgia-like illness? And maybe we have to think of a small fiber neuropathy as well, if they have predominantly neuropathic quality to their symptoms, because the differential diagnosis and prognosis might slightly differ. So the same disease, at what time point you see can matter. So if you see a preclinical autoimmunity, it can look like fibromyalgia, but in 6 months' time, they look like rheumatoid arthritis. It's the same flower at different stage of its evolution. They can look totally different. So sometimes the diagnosis in rheumatology can be working diagnosis if you are not getting a clear-cut autoantibodies and correlation. So we keep it as a working diagnosis, probable rheumatoid arthritis. If you have that diagnosis, then you'll always think that it is not a definite diagnosis. You will start thinking of a differential diagnosis at every visit. Depending upon what clue patient gives, you might change the diagnosis. So the diagnosis is a working diagnosis. And we all know about thyroid disease, Hashimoto's, masquerading as muscle aches and pains. Parathyroid disease can present with musculoskeletal and aches and pains. Hypoadrenalism is not an uncommon cause for severe fatigue associated with myalgias. Even testosterone deficiency can cause muscle pain and muscle disease. And diabetes is, particularly the glucose toxicity, the early diabetes or undetected diabetes is not an uncommon cause for aches and pains. So basically, when we suspect this, we look at the usual tests we do to rule out endocrine diseases. And these are the drugs which I was alluding to. Statins, we all are familiar. We also think of antiretroviral therapy because many patients may not come out with this question, topic unless it is specifically asked for. And remember that ethanol is also a drug and it is a myotoxin. And so this could be an occasional alcoholic, the occasional can be every other day. So it can be contributing to the muscle aches and pains. Anastrozole, which is given for CA breast prevention, is an important cause for aches and pains. And if you look at the other list, almost all drugs can cause aches and pains. And bisphosphonates are very commonly caused, statins. Even antidepressants can cause aches and pains as a side effect. So the drugs we use to treat pain can cause pain. So this always review the drugs as a potential cause for pains not getting better. Once you roll this out, then probably we come to the basket which we are going to consider today: fibromyalgia, depression, somatization illnesses, and multiple regional pain syndrome, hypermobility, and small fiber neuropathy. Today's focus is on fibromyalgia alone. So there is no diagnostic test for fibromyalgia, and it is not a diagnosis of exclusion. So there is no need for you to do an extensive battery of tests to exclude other diseases to make a diagnosis of fibromyalgia. And the exclusion does happen at the history level, physical examination level, not at the blood test level. This is an important point I want you to stress, I want you to remember. And there is no need to do an ANA, rheumatoid factor, ANCA, everything before we say it is fibromyalgia, because some of the tests will come positive and it can confuse us. And unless there is a specific clue, don't do autoantibody test. But yes, basic test like blood count, CSR, CRP, depending upon the thought process you have, endocrine tests, sugar, vitamin D, B12 may be in place and not routinely autoantibodies. So the exclusion happens at a history level and physical examination level rather than at a lab test level. So this is the one point the one take home point I would want you to carry. And I alluded to this earlier. Look at fibromyalgia in any rheumatology patient. It gives us an alternative explanation for pain and symptoms. It helps us interpretation of disease activity measures like DAS28. Patient looks okay, but they has a high DAS28 because this could come from a high tender point score and a high patient VAS. So we can, instead of increasing the immunomodulation, we may be able to give her a different pain modifying drug like gabapentin or refer them to cognitive behavior therapy, etc. So include this in the first consult. Look at fibromyalgia at the first instant itself so that you are aware of this from the beginning. But at least consider when your treatment is not going in the right direction. As you have understood by now, the chronic pain is a different animal compared to acute pain. They don't respond to NSAIDs. The pathway is totally different and it is a disease by itself. I don't know how many of you have listened to the story narrated by some other doctors, or some of teachers might have told you about the story of very interesting case published in 1995. This is a factory worker. When he was jumping from one place, he get a nail goes through his shoe, and patient was in agony and he was crying in pain. And he was taken to the office because nobody wanted to take the nail out because they didn't want to injure the tissues inside. He was sent to the hospital with the nail intact, and hospital staff carefully cut the shoes out. And patient was in agony and he was crying with pain. So when they cut the shoe, they have seen that the nail has nicely gone between the toes like this. And totally there was no injury at all. So it is the mind, looking at this gory picture, the mind thought that there is a big injury and he was crying with pain. So this is an example. So there is a huge effect of mind over the body. There was also an experiment done in Indian prisons in maybe early 1900 or late 19th century. The English physician has taken a permission from the court to do an experiment on a patient who was about to be hanged the next day. So he put an IV line and told that instead of hanging, I will give you a painful death. So patient agreed. And they put an IV line Until that, I'll slowly bleed you. And as the bleed goes, the last drop of blood goes, your life goes away smoothly. So you won't have any pain. There is no neck throttling, etc. So the person was also very happy. So they did the experiment. So he actually didn't put an IV line. He put a fake IV line, and they closed their eyes, and they simulated blood dripping into a bottle, into a bucket downside. So there was a sound of blood dripping down, and he was constantly giving him a suggestion that 1 liter is gone, 2 liters is gone, you have 5 liters, now 3 liters is gone, 1 liter is gone, the last few drops and everything is gone. By the time the last drop is done, the patient was dead. So the title of the article, I don't have access to the original article, but I read it in another book. It was called Death by Suggestion. So there is a huge effect of mind over the body. So we need to recognize this. So what happens in these patients? They have a low pain threshold. So what causes the low pain threshold? Genes load the gun. Environment pulls the trigger. What is that environment? This is called the concept of exposomes. I'm sure you must be familiar with this concept. Whatever human beings have been exposed from conception to current date, whatever we were washed with environmental factors, including what our mom ate when we were in the womb, and whatever stress they have had, what food was available, and after the birth, whether it's a vaginal delivery or a C-section delivery, what kind of microbiome the kid is exposed, whether it is vaginal microflora or the microbiome from the nurse's hand. So this all determines the illness, and childhood experience, toxins. So this is the exposomes. Depending upon which genes you have and where is the weak link, and somewhere something snaps and we get a disease. So, and for the first time in human evolution, the last 150 years or 100 years, we have been exposed to such a load of chemicals and things which were unknown to evolving humans in 99% of the human being existence, like electromagnetic radiations, chemicals, toxins, pesticides. We don't know. So that's the reason I think we are seeing more medically unexplained illness than medically explainable illness. So this is the exposome concept. And there are few observed abnormalities in fibromyalgia: autonomic nervous system, HPA axis, and also few endocrine abnormalities, and low level of serotonin, high levels of substance P. And also there is suggestion that microglia is activated, suggesting there is some central inflammation contributing to the pain experience and sensitization. This is a nice diagram which gives you the idea. Genetic predisposition. Exogenous stress leads to sympathetic hyperactivity that can explain some of the symptoms like insomnia, dryness of the mouth, irritable bowel, etc. Over time, increased exposure to sympathetic hormones can lead to receptor desensitization and hyporeactivity. The patient can develop fatigue, which same process can lead to dorsal root sympathetic sprouting, allostatic loading, and it can lead to neuropathic type of pain. So this is one model of fibromyalgia pathogenesis. And the another concept which can be used to explain FM to the patient is volume setting, volume control, which has got a genetic determinant. We must have seen our own friends. Somebody give them a handshake. Some people will wince, and some people will not even recognize. Even if you go and give a big bang on their back, they won't even turn back. They'll continue to do what they were doing. So the pain threshold can vary depending upon the volume setting. And it is like a bell-shaped curve. Some people have a low pain threshold. Some people have a high pain threshold. So if you have a high volume setting, you will experience more pain. Or in other words, you have a low pain threshold and you will hurt more. This is a simple diagram of nociception. And there is two pathways. There is a nociceptive pathways and also descending inhibitory pathway. The defect in seem to be in the descent, both sides. There can be hyperexcitation in the ascending pathway and decreased activity in the descending pathway. There is morphine endogenic what do you call that? That pathway is overloaded. That's the reason morphine and similar kind of drugs don't work well in fibromyalgia. And there is a defect of descending inhibitory pathways through serotonin. That's why enhancing the serotonin seem to help restoring the descending inhibitory pathway and help the patients. So is it all in the mind? Yes, because more chronic the pain is, less nociceptive is the cause. And the pain becomes more and more brain pain. So if there is no brain, there is no pain. So it is not, patients are not faking it, but the pain is always perceived in the brain. So in a sensitized state, nociceptive signals can increase by 100 times or many hundred times. One simple example I'll tell you. So if the pain is basically is a nociceptive stimulus, it is a warning sign. So whenever we experience pain, we want, our brain wants us to run away from the pain, run away from the danger. So that is true for acute pain. When you try to touch something hurts, we justly withdraw. When you try to sit in a place, there is something sharp there, we immediately get up. And if there is any painful, something comes here, we generally move to evade the pain. That serves our survival. But when there is, for some reason, the chronic pain is there in the body, which doesn't have a survival advantage, but sometimes our subconscious brain doesn't recognize that, and it wants us to run away from the pain scenario. When we are not running away, because we don't know where to run away, from what we are going to run away, and then brain thinks that I'm warning this person, and he or she is not running away, and it amplifies the signals. That's the reason little bit of amplification happens, and the patient starts perceiving more and more pain. That is the reason something which can calm down the brain can help to deal with the pain in a much better way. Of course, this is a slide on sleep, and we generally, 25% of our sleep is spent on a deep sleep, and fibromyalgia patients hardly have a deep sleep. So they don't have the restorative sleep. And unless you improve the sleep, most patients with fibromyalgia don't really improve. This is a concept we can use in your clinical practice. Pain can lead to reduced activity. Reduced activity can lead to deconditioning. Deconditioning can lead to more activity. Because of the pain, you don't sleep well. Because you don't sleep well, you get more pain. You go into a downward spiral. So this concept is useful to explain FM to the patients. So FM pain is a different pain, and it's a continuous pain, not much of a pain-free intervals, vis-a-vis inflammatory pain. It's widespread, deep felt in the muscle, and it can increase during the physical activity. They hurt all over. Stressful scenarios worsen the pain. And the more widespread the pain, the more likely that it is FM. And the stiffness and pain and paresthesia are generally non-dermatomal. And so these are the characteristics of FM pain, which helps us to differentiate it from the usual nociceptive pain. So coming to treatment, we use the knowledge we have now to design the treatment. The pregabalin and gabapentin, which are properly commonly used, work on the ascending pathway by reducing the hyperactive signals. SNRIs and tricyclics enhance the descending inhibitory neurons by increasing the serotonin levels. And other drugs like low-dose naltrexone can help in reducing the central inflammation. There are drugs like metformin, drugs like enalapril can also have some role in reducing the central inflammation. The animal data is quite reassuring. So we might consider particularly these drugs when there is a comorbidity. And we have a equally strong non-pharmacological therapy. And these are the medications which are used for sleep, and many of them are also used for pain. Gabapentin we can increase the dose to 1,200 milligram easily. Pregabalin, we can go to the dose, usually not more than 200. We can go up to 350, 400, but for FM purpose and sleep purpose, that is a good dose. Topiramate can increase the deep sleep. Baclofen, magnesium, these are the things we can use. And occasionally we use sedatives and sedative antidepressants like trazodone, amitriptyline, mirtazapine, melatonin. These are all deep sleep inducing drugs, and many of the drugs like amitriptyline also are helpful for pain. And there is no specific drug which helps for fatigue except probably modafinil and bupropion. No? I'm not getting the right name. There's an antidepressant. So some of them are energizing antidepressants. So you should be able to use them for that specific purpose. FM has multiple domains, like what we have multiple domains in ankylosing spondylitis. So we have to focus on drugs which can use on you can be useful in multiple domains. And therapeutics are disappointing efficacy because most drug can provide only up to 30% improvement in 30 to 50% of the patients treated, even in clinical trials. And most drugs are not well tolerated in recommended doses. The full dose used in pregabalin trial is 450 milligram. Our patients hardly tolerate more than 150 milligram. So we have a problem there, achieving adequate therapeutic dose and therapeutic effect. High dropout rates because patients also are very sensitive to many drugs because of the nature of the disease itself. So number needed to treat is 8 for duloxetine to produce 30% improvement in their clinical symptoms and pain. So many of them don't produce a meaningful reduction. 30% reduction looks statistically nice, but may not be meaningful for the patients. And being a multi-domain disease, you need multiple drugs with overlapping actions and side effects. So we use pregabalin and amitriptyline. Drowsiness can increase. That can affect their driving and function, particularly if they are working with kind of situations where require a lot of mental effort, like IT, teaching, medical profession, etc. And as we discussed, drugs also can cause side effects similar to fibromyalgia symptoms. And patient education is very important, at least if they know about the relationship between the pain and what's the nature of pain, the connection between sleep and exercise and pain, the knowledge about maladaptive behavior. All these things can help them to understand the disease so that they don't get scared of the pain. So they can deal with the pain. Sleep is an important aspect of treatment. There are a few sleep hygiene which I can quickly run through if you want. It is available online in PDF forms, sleep hygiene. If you just Google, you can get it. So going to the bed at the same time every night and making the bedroom quiet, dark, and comfortable, removing all the gadgets from the bedroom, switching off electromagnetic like Wi-Fi and router, etc. Because electromagnetic waves can affect the brain. Brain is also electrical, can affect the sleep in patients who are vulnerable. Not everybody, it may be somebody who is vulnerable, it can affect deep sleep. And using the bed only for sleeping and intimacy and not for other activities. Most people do their office work sitting in the bed. So that reduces the sanctity of the bed, and the going to bed will not automatically invoke sleep. Physical activities can promote sleep, but avoid physical activity just before going to bedtime. The best time to do physical activities in the evening so that you feel a little tired and helps you to sleep. Avoid large meals before the bedtime. Have at least 2 to 3 hours before bedtime. And daytime napping, most people do. And more than 20 minutes can affect the sleep quality in the night. And leading a circadian rhythm related lifestyle. So getting an outdoor light exposure within 1 hour of waking and several times a day can reset the circadian clock. And trying to go to sleep between 10:30, 11 and waking up at 6:30, 5:30, 6:30 is the best time, because the most the deep sleep happens in and around 12 o'clock, 1 o'clock window. So if you miss the sleep, even if you sleep around 4 o'clock to morning, next day to 1 o'clock in the afternoon, you don't get that deep sleep well. Exercise is strongly recommended by EULAR. It improves many domains like pain, fatigue, etc. Adherence is poor because fibromyalgia patients have too much of pain. Their exercise tolerance can be sometimes a problem. But starting slowly, gradually increasing, easing into an exercise program can help. And they can conserve energy during activities by doing pacing, and so that they can spend time in structured exercise program. And doing exercise between 10 a.m. and 3 p.m. That is our best capacity time, rather than do after a long day of work. And using a warm shower or some pain medication before exercise also can be useful. This I strongly suggest. They can choose an exercise of their choice, exercise they enjoy most. It can be dance, it can be Tai Chi, it can be yoga, it can be simple Gaga dancing. Gaga dancing, just Google Gaga dancing. It's up, just sit and do whatever you want is Gaga dancing, moving your body. So that's important, is move your body. And I have found that if we write exercise in the form of prescription, like Mrs. Ruma, 32-year female, walk 10 minutes a day for a week, then make it 20 minutes a day for a week, 30 minutes a day, and then continue 30 minutes forever. Stretch 2 or 3 times a week. Do some weight training with 1 kg dumbbells or a closed water, 1 liter water bottle for 20-30 minutes, 2 or 3 days a week. Write and sign and give. Their adherence can be slightly better rather than just telling that go and exercise. And CBT is a good tool, and patients have a reluctancy in going to a mental health professional. But if they are convinced, CBT can address sleep, pain, and affect. They generally help with the pacing, graded activation, the relaxation, pleasant activity scheduleness, and they focus on mindfulness. So it is as effective as pharmacological intervention. And this is my last but one slide. So self-management, we have to empower our patients because pain may not go away. So complete pain relief is not the goal. So managing the pain, improving this efficacy is important. And also calming down, keep telling themselves that there may be pain, there is no harm. If pain is there, there is no permanent damage is happening. They keep telling themselves the brain will calm down and it will not amplify the pain. And the pacing is an important tool. What I mean by pacing is breaking the activity before it causes pain. For example, like typing for half an hour induce a lot of crampy pain in the forearms. Don't go up to 30 minutes. Stop at 20 minutes. Break your 1 hour activity into 3 20-minute activity rather than continuously typing for 1 hour and suffering. So you have to stop before pain comes so that the pain begets more pain. So you avoid getting into severe pain. So you may be able to manage and reduce the suffering. Another concept is pain is sometimes inevitable. Suffering is optional and also is negotiable. So we have to negotiate with the patient that pain may be there, but the suffering component we can negotiate with the patients. So the idea is to treat pain before it becomes severe. And if you find any nociceptive stimulus like myofascial trigger points or an osteoarthritis or a slight flare of rheumatoid arthritis, treating them with steroid, local injections, etc., can reduce the pain bombardment to the nervous system and reduce the amplification of pain. So another concept I want you to take is exercise snacking. They may not be able to do exercise, they may not have time. So every 2 hours of working, they can take 5 minutes break and do some stretches. Many people are working from home. It is easy for them to do. Even as a doctor, if you're working continuously, but say 10 to 12, you are seeing a patient, take 5 minutes up, just get out of the room, go up to first floor, second floor, come back and start seeing the patient. Or if you want a low break, don't go to the toilet nearby, go to the toilet in the first floor or second floor and come back. That can be a good exercise for us. If you do it 2 or 3 times, by the time the working hour is over, you would have done accumulated 20 minutes of exercise. That's called exercise snacking. And also some patients use alternative modalities. If they are happy with some safe modalities like an acupuncture, homeopathy, Reiki, don't criticize them. And if they're happy, as long as you perceive it as safe, it's okay for them. When you say it's okay, that also builds their confidence in you and they will listen to you. Lastly, ladies and gentlemen, can we prevent pain? It's difficult. It may be useful for people like us, doctors who are in stressful profession. It's good to have a stress coping bank account and have more deposits. Sleep well, sleep at the right time, sleep for 7-8 hours, move your body in whatever way you like and enjoy. Have a healthy diet, avoid junk food and processed food. Try to spend 5-10 minutes in doing some pranayama, meditation, mindfulness, and 5 to 10 minutes of not doing anything. Have a purpose in life. Most of us do have purpose. Have more friends, interact, attend IRA meetings, interact with all our colleagues, friends. Away from rheumatology, have another group of friends. Having a happy married life, spend some time with your wife and children and our husband, spouses. And that would definitely make life easier. And that acts as a deposit into stress coping account. Have a lot of fun, have laughter, and have less withdrawals. Just opposite of whatever I told is a withdrawal. So have less withdrawal and wish you a pain-free and happy life. Thank you. Thank you for patient hearing.
Thank you, sir. It's really very great talk. So fibromyalgia is a challenging reality. And I really like the exercise snacking point that you elaborated, and we shouldn't be criticizing fibromyalgia patients. So I think, sir, you can take a few questions from the attendees who are there today, faculty or students. Please ask. I wanted to ask, sir, risedronate or bisphosphonates, how often do they increase the pain, the musculoskeletal pain? Because we give it for osteoporosis.
Yes. Okay. Literature says up to 10 to 15-20% of the patients with risedronate may have musculoskeletal pain. See, how we look at it is, if you are starting a patient on risedronate or like alendronate, after that they seem to come back to you with more pain. Think of this as a potential cause and switch over to something else and see. So if you don't consider it, then we will end up giving one more medicine for that pain. So it increases the polypharmacy. That's what I wanted people to remember. Keep drug as a potential choice. If somebody comes to you with leg edema, somebody is on amlodipine. First thing is to stop amlodipine rather than doing an extensive investigation, renal, cardiac, liver. So before that, if you stop amlodipine, edema goes and patient is better and patient is very impressed by your acumen and we have not spent money. So the same principle I was trying to tell you.
There's one question in the chat box by this. Can we use COX-2 selective inhibitors for fibromyalgia pain?
Generally, most of the pain in fibromyalgia is non-nociceptive pain. NSAIDs are generally not useful. There is no special role for COX-2 inhibitors. If there is an element of osteoarthritis or an element of nociceptive pain, a short-term non-steroidal can be given, provided there is no contraindication to it.
Any other questions, madam? Which way, madam?
Sir, Sunil from Mumbai. Kavita ma'am, if I may ask.
Yes.
Sir, I have few patients who are on CBD oil, cannabinoid oil, and they claim excellent result, all the fibromyalgia patients from this. So I just wanted to know your experience and where is cannabinoid in terms of treatment of fibromyalgia at the present time?
The cannabinoid and the cannabinoid related has become like the current hot topic in the pain circles and patient circles, and because of its association with marijuana, and people are a little excited about it. And some countries have legalized marijuana, and but the trials have been disappointing. The trials they have done on chronic pain with cannabinoid has not been very useful. But an individual patient who uses a cannabinoid oil externally, and if they are happy with some of the medicine, it's okay to take it. It has got a reasonable safety. But smoking marijuana probably is not to be encouraged because it does have an addiction potential and it can have a long-term. We should not replace opioids with cannabinoids and create another monster. But the ones which doesn't have THC, that addictive component, if their patients are happy, which can nothing wrong in continuing, may have a huge placebo effect because when they give the CBD oil, it's great, marijuana related, the patients do feel the placebo effect is huge in chronic pain.
Can you elaborate?
Thank you.
In the chat box, there's a question. Can you elaborate about the autonomic dysfunction in fibromyalgia in brief? We have discussed.
Autonomic dysfunction is, see, some of the fibromyalgia patients, particularly when they have chronic fatigue syndrome, they have postural intolerance, like they have POTS, they have a postural hypertension, and they don't enjoy doing things upright position. So if these patients generally have more chronic fatigue spectrum, it's like an overlapping area. Some people have, they are more prone for infection. They look like they have some immune dysfunction. They have severe fatigue as a dominant features. And some of the fibromyalgia patients also have some form of that autonomic dysfunction. Some of the patients may have small fiber neuropathy presenting as autonomic neuropathy. These patients probably will look for potentially irreversible treatable causes like Sjogren syndrome. We should look for sarcoidosis and a few other diseases, diabetic. We should be able to look for these secondary causes of small fiber neuropathy. Otherwise, treatment is very similar, using stockings, avoiding sudden getting up, and using drugs like Ivabred to reduce the heart rate, drinking enough water, electrolytes, and there are drugs which can increase the blood volume.
How long would we wait till before saying that the drug isn't working and change the medication drug in fibromyalgia?
The full effect of most of the drugs will take at least a couple of months. If you are starting them on amitriptyline, and we have to wait, start with low dose because we don't know how they tolerate. So start with 10, 15, 20. Somebody coming back with 1 hour crying, they're not better at all. These are the patients have a lot of emotional distress. See, a typical fibromyalgia patient comes with a lot of aches and pains of 1 year duration. You examine, you come to a conclusion and start them on amitriptyline 10, call them back after 2 weeks. Okay, if they're not better, they tolerate it, increase it to 25. So that pattern is like a typical standard fibromyalgia patient. But the patient who came with severe pain, crying with pain, so you started on amitriptyline 25, with pregabalin you started 50. Within 4 days, they come back crying that there is not even a improvement pain. These are the patients, I think the emotional component is very, very strong. I think we should start looking at the person behind the patient. These are the patients who may have domestic violence. They may have some other distress as a dominant feature. This is a clue. The patient who cries in your clinic and have a lot of verbal, particularly the woman comes with her spouse or her father-in-law or mother-in-law, they keep looking at the eye contact. They're trying to, whenever they give an answer, they're trying to look at the husband's reaction. These kind of patients are all cues to say that patient may have a distress. Sometimes talking to them in private they'll start crying with all this problem, indifference to their pain, lack of support from society, social. So that's the importance of looking at the person behind the patient. So we have to be little aware of the cues, non-verbal cues the patients give. So we should be a little more open to that.
Yeah. Any more questions from the audience? Dr. Rohini, are there? Dr. Rohini?
Yeah, I'm there. Can you hear me?
Yes.
A little louder.
Okay. So, no, I have nothing to add really, just to thank Dharmanand. And I think it was a very practical lecture. And he's really, the experience shows when
we can't hear you.
How common is the brain fog in fibromyalgia?
It's quite common, ma'am. It's quite common, and it's a very difficult things to treat. The thing which can improve the brain fog is exercise. Exercise improves the brain-derived neurotropic factors, and through many, even myokines induced secreted during exercise can cross the blood-brain barrier and improve the brain fog. And dietary interventions sometimes, not always, asking them to be vegan for a couple of weeks and try. Some people become better. So this is little trial and error. I don't think we can base anything on a randomized control trial. It is your experience. Sometimes when things are not going in direction, I ask them to say, stop everything and come back and see how you are. Some people feel better. And giving them omega-3 fatty acids, turmeric can make their brain fog a little better.
Any other questions?
Thank you.
Yes, you can wind up. I have somewhere to go.
Yeah. Dr. Rohini, are there?
Go for an inspection for Hirakan 24 venue. So Chandrasekhar and Nagaraj are waiting and calling me.
Yeah.
Right.
Thank you, Kavita, Sunil, and Girish also for conducting these meetings so well. And the ongoing program, I think the students attending, everything seems to be
I think we can't hear you well, Dr. Rohini, but on what she's saying is thank you so much, sir. Thank you so much for joining us today. We're really enlightened. Yes, sir. Good day to everyone. Good day, happy Sunday evening to all of you. Thank you once again. Bye-bye.
Thank you, Kavita. Thank you, Kavita.
Bye. Take care.
And all of you.
I'll close the meeting. Thank you, everyone.